Good afternoon, everyone, and welcome to the second session of our Dystonia Education Series. I would like to introduce myself. I am Apurva Zawar, neurophysical therapist and founder of Beyond Rehab, a virtual neuro rehab and wellness clinic specialized in working with dystonia, Parkinson's, functional neurologic disorder, and chronic pain. You can learn more about us at beyondrehab.health. Today, I'm joined by Dr. Khemani, and we are excited to continue this expert three-part series with you. Goal with this Dystonia Education Series is to deepen your understanding of dystonia, explore available treatment options, and discuss strategies for effective care coordination. Each session aims to provide practical guidance and up-to-date information, but please remember this is for educational purposes and not a substitute for personalized medical advice. Before we begin, a quick reminder to please fill out the feedback survey from last month's session if you haven't already. It really helps us to improve our future events. And we'll like to get started with today's topic. So today we'll be discussing two main themes. First is mainly about functional dystonia and the use of Botox in managing functional dystonia, if there is any efficacy or reason behind it, and looking into the neurorehabilitation approaches in dystonia management. Quick housekeeping rules. Please stay muted unless invited to speak, as we'll be recording this. The session is being recorded, so make sure feel free to turn off your audio, video, and drop your questions in the chat anytime. We'll address them during the Q&A. Thank you again for joining and excited to get this started. So, we've been discussing a lot regarding functional dystonia diagnosis in itself. So, if you could explain what does that mean? How is it different from just a dystonia diagnosis?
Yes. Okay. So that's the first question. Well, in order to diagnose any functional neurological disorder, you have to know what the underlying neurological disorder is that it is mimicking. So functional dystonia mimics dystonia, so one needs to have an understanding of what dystonia is. That's really important because you don't want to miss a diagnosis of dystonia. And an article just came out actually just last month, redefining dystonia and reclassifying it. And from that article, I'm going to read out exactly the definition of dystonia. So, dystonia is a movement disorder that is characterized by sustained or intermittent abnormal postures or both. So just break down the first sentence. The intermittent postures would be a jerky tremor. A sustained posture would be a tilt or a turn in a specific direction. And then dystonic movements and postures are typically patterned. What that means is usually it is the same muscles that are hyperactive in dystonia, whether you examine the patient in January or June or December, the pattern needs to be consistent. For instance, if there is a tilt to the left,
Mhm.
and in January, it's highly unlikely that there's going to be a tilt to the right in June. That pattern is maintained. So that is important. And then dystonia, dystonic postures and tremors are made worse by action. So we all often hear physical exertion, movement, exercise can make dystonic postures worse, and also can make these intermittent jerky movements worse. Not everyone with dystonia has a tremor. And in fact, the norm is to not have a tremor, or that's the vast majority of people. Um, anyway, so once you have the definition of dystonia, if you turn it on its head, then we get the definition of something that is not dystonia,
Mhm.
right? So that's important. And functional dystonia falls into the category of those disorders that are not cervical dystonia or dystonia. So, and it can be confusing because Um, I think it was Dr. Steve Frucht from New York who said we should stop calling functional neurological disorders by the same name we use for neurological disorders that are not functional. So if you call something dystonia, then it creates confusion in the patient's mind. Well, you're calling it dystonia, but then you're telling me it's not dystonia. This is very bad use of language.
Mm-hmm.
So I don't know what the term is that's going to replace dystonia for functional disorders, but Dr. Fruch says use the term dystonia-like.
I
Okay.
see.
It's still is not very clear. We don't have another term, so we use the term functional to clarify that, okay, this looks like dystonia, but the mechanism of development of this dystonia or dystonia-like posture
Mm-hmm.
is not uh, similar to the mechanism which causes neurological dystonia to develop. And even that is a little muddy because functional dystonia is also neurological.
Mm-hmm.
Uh, all of this is coming from the brain.
Mm-hmm.
So if you have a posture or a movement that is not patterned, that is the first red flag that it is likely not dystonia. The pattern changes.
Mm-hmm.
And that's not to say that you can't have a tremor that's going from right to left or up and down. That's perfectly okay. And then the second thing that is that the definition mentions is the repetitive quality or the tremulous or the jerky quality. That is fairly common in cervical dystonia and other dystonias. In functional dystonia, we don't see a lot of that unless there is a functional tremor that is coexisting with the dystonia. So
Right.
this is also important to recognize that there is a whole category of neurological disorders that are functional. There's functional dystonia, functional tremor, functional Parkinsonism, functional chorea. So the term functional becomes important. And truly, even that is a misnomer because what functional means is this is a condition that is disrupting function. You're not
Mm-hmm.
able to function well, but so does cervical dystonia. So our
Right.
choice of words is terrible.
Mm-hmm.
Um, Previously, functional used to be classified, it still is, according to the Diagnostics and Statistics Manual, as a conversion disorder. And it can still be called a conversion disorder. That is a
Right.
much better term than functional, etc., but it has a stigma or a label of being a psychological disorder. So that's why messaging becomes difficult to patients. So movement disorders, doctors try to use the term functional. And also, it's important to recognize that now we know the functional dystonias are generated by parts of the brain. There is no mind,
Mm-hmm.
all brain. And we'll get to that in just a little bit. So when we have these red flags of non-pattern behaviors,
Mm-hmm.
then we worry if it's functional dystonia. But I wrote down a list of other things that can look like cervical dystonia. They're not cervical dystonia, and neither are they functional dystonia. So
Mm-hmm.
just because it's not cervical dystonia or not dystonia doesn't make it functional. And it functional has inclusion criteria. So what are the things that can look that are dystonia-like, but not dystonia? One is pseudo dystonia. Terrible word. Pseudo dystonia is I got pain here, so I'm holding my neck this way. It is purely a function of guarding. You're guarding because of pain. You
Mm-hmm.
have some instability or pain going on, which is forcing you to adopt a posture to prevent pain.
Mm-hmm.
And this is the exact opposite of dystonia because in dystonia, the muscles are twisting and turning in a direction to cause pain.
Mm-hmm.
right? That causes pain. And try as you might, you can't go to the opposite direction, or if you can, it's just temporary.
Mhm.
And then you're right back to that posture. So pseudodystonia needs to be. Let me just shut. Yeah. So pseudodystonia is that. So one needs to. One needs to make sure. One meaning the physician needs to make sure that other causes of the abnormal posture are being identified.
Right.
Cervical instability, and again, I'm talking about cervical dystonia more than other dystonia because that's the most common in our clinic. 80% have cervical dystonia. So let's focus a little bit on that. It's easy for explanation purposes also. Atlantoaxial subluxation, fractures of the spine, many things can cause instability and result in abnormal postures. That doesn't make it dystonia. So it's incumbent on the physician to think beyond dystonia and make sure other things are not going on. Now, sure, if you come to our clinic after 20 years of having an abnormal posture, it's highly unlikely to be an unstable spine because you can't live for 20 years with an unstable spine. You could become quadriplegic, you could have something happen to you. But if someone just walks into your clinic saying, yesterday I had this horrible pain and my neck is this way, that ain't dystonia at all. You have to look for what caused that pain yesterday. So then again, we talk about onset. Dystonia starts gradually, usually, not always, usually cervical dystonia starts gradually and builds up, has a memento, reaches a peak after a few months, sometimes even years. And it gets worse as time goes by. It doesn't get worse continuously. Maybe the discomfort does, but the tilt or the turn reaches a maximum, sort of a plateau, unless there's a physician who intervenes right before that maximal plateau is reached and starts treating it. So it's a fairly gradual curve for most dystonias. And even during the day, you'll see dystonia worsening as the day progresses. So there's a diurnal pattern for dystonia. Functional dystonia typically typically starts suddenly, and starts under a certain kind of stress is a very loosey-goosey word. Pressure. There's a pressured environment. Go, but again, see, that's important to recognize that not everyone with functional dystonia has a pressured environment or actual stress that they're aware of. And number two, pressured environment and actual stress can also set off cervical dystonia.
Mhm.
And so one has to be careful in terms of categorizing this. But again, the onset is typically acute. I had surgery, I woke up and my neck was this way. Now, that could be acute dystonia. All right. And that is treated with immediate medications because there are certain anesthetics and oral medications that can cause acute dystonia that is completely reversible. That's sudden dystonia. So therefore, that needs to be differentiated as well. Is a sudden insult to the brain or spine or a medication causing dystonia. And
Right.
so if the medications are causing dystonia, they can be classified as acute and tardive. Acute is immediate. You take a pill and it causes dystonia, and that's happened. And tardive is antipsychotics being taken for a long period of time for things like schizoaffective, schizophrenia, severe depression, severe anxiety, etc., causing dystonia down the road. That is drug induced. So then the treatment of that is slightly different than the treatment of sporadic cervical dystonia, which is caused for by we don't know what. So there's another theme I'm weaving into the cause, which is typical cervical dystonia that is seen in the clinic doesn't have any specific cause. We really
Right.
don't know what causes it
Mhm.
yet. Okay, so we have to look for in dystonia that doesn't satisfy this category of. We have to look for instability of the spine, lesions of the brain, myofascial components causing severe pain that are causing the person to hold the neck a certain way. You have drugs that are causing dystonia. You know, so if so, those have to be considered because that's a different kind of dystonia. And then there is functional dystonia, which does not, like cervical dystonia, have a particular lesion. You do the brain MRI, you do the cervical MRI, you look at the blood tests, you look at everything, everything is normal. Okay, so that is one characteristic of functional dystonia, which can be seen in cervical dystonia as well. Number two, the non-patterned sort of muscles, sometimes left, sometimes right, sometimes up, sometimes down, that variability. Number three, acute onset, sudden, very suddenly, and four, a background of severe stress. What we know from functional neurological disorders is they're more common in women than men. That's number one. And number two, 70% of the people who have functional neurological disorders have been under duress or stress for a long time, and not acute stress. And when you look in the past, it could be medical stress, numerous medical problems. It could be psychosocial stress, marital issues, issues with parents, etc. And then a majority of them, I would say, also have some history of abuse as a child. So functional dystonia is also accompanied by other psychiatric comorbidities that need to be recognized, which are very different from the non-motor symptoms of dystonia we talked about. The non-motor symptoms of cervical dystonia are the sleep, the mood disorder, but not necessarily chronic severe depression, depression that goes with it, anxiety, social phobia, isolation. Those are the non-motor symptoms that should be addressed. So there are some psychological components of cervical dystonias, but with functional dystonia, the psychopathology or the psychiatric disorders are fairly severe. Let's just say that. Another clue that something is a functional dystonia versus cervical dystonia as the lack of gest antagonist. There is a sensory trick that some dystonic people have: chin, cheek, resting the head back, etc., that can minimize dystonia. And that's not typically seen in functional dystonia. What makes the diagnosis of functional dystonia very complex is when both functional dystonia and cervical dystonia coexist. And that can happen. And we've seen that in our clinic. So how do you diagnose functional dystonia? You do need a movement disorders doctor to be able to diagnose it. I can guarantee you primary doctors, general neurologists, stroke doctors, epilepsy doctors, none of these doctors have the tools or the experience to diagnose functional dystonia. You gotta go to a movement disorder. If a general neurologist tells you of dystonia, take that at face value, but go confirm it by a movement disorders doctor. Even we are wrong, maybe 50% of the time, because there is no test. You have to follow the patient periodically to make sure that you've made the right diagnosis. So it's very complex. But
I agree.
the diagnosis can be made. If you have enough tools in your toolbox and you have enough experience, then these are the criteria for functional dystonia. Your second question was Botox.
Yeah.
Botox is truly a blunt instrument. Botox causes a decrease in the transmission of acetylcholine, but also the transmission of other neurotransmitters that cause pain. So if I have a myofascial spasm and I go into the doctor's office with a raised shoulder, which is causing me pain, and someone injects Botox there, my pain becomes, lessened and my shoulder relaxes. That does not make it dystonia. And then that's the other thing is, you have looked for causes of pain. Is this dystonia kind of a thing? And so the diagnosis of dystonia is clinical. It should not be made solely based on whether it responds to Botox or not. On the contrary, a corollary is if someone has cervical dystonia, unless they're immune to Botox, they will respond to some degree, right? So that's important too. So it can go either way, is that if someone does not have a response to Botox at all, could there still be cervical dystonia? Yes, if they're immune to the to toxins. Number one. Number two, if they respond really well, does that mean that they have cervical dystonia? No, not necessarily, because Botox is a blunt instrument and decreases neurotransmission of pain, etc. And so, you know, that's something that needs to be taken into account. And then why is the diagnosis of functional dystonia important to recognize and make? Because in the first couple, 2, 3 years, it's completely reversible. Cervical neurological dystonia is not. It stays with you, it may get worse over time. But with appropriate treatment, PT for motor retraining, cognitive behavioral therapy for functional dystonia, you can actually reverse 80% of functional dystonia, and the patient does not need any injections or drugs or anything at all. So that's how different the treatments are for functional dystonia and for cervical dystonia. In terms of resources, you have to be able to send the patient to a physical therapist like yourself
Mhm.
who has knowledge of dystonia and functional dystonia to do motor retraining, and someone who is knowledgeable about cognitive behavioral therapy. And then there's other resources that are available online. There is there's one resource called DNRS, which
Mhm.
is a neurological retraining system. And then on Amazon, there's actually a book that I pulled up that says, well, let's see, and the name of the book is Overcoming. I just can't find it now. Overcoming Functional Neurological Symptoms.
Mhm.
Let's see, I hope there it is here somewhere.
Is it the workbook or
Yeah, it's a
just
workbook. I'm sorry. Yes. Yeah, so you know about that. Anyway,
yeah?
so I'm just going to stop here because it's 26 minutes into the meeting, and you all have questions, and Apurva has a lot to say. At this point, Apurva, do you have any questions, or was this explanation adequate?
Yeah, this was really important because this keeps coming. Like one common theme is Botox important with functional dystonia? So you covered it, and yeah, and it's a good starting point to differentiate between idiopathic and functional dystonia. So we could.
Yes, and then you can go into, I didn't use the term idiopathic because we never talked about the various causes. We did talk about some of the causes of dystonia, but not all the categories based on causes. Idiopathic, sporadic, genetic, neurodegenerative, there are many, many causes. So what I'll do is I'll just hand y'all over to Purva, and you can continue the meeting, and then I'll see you all back in clinic. If you come to my clinic, if you have questions or concerns, you can talk to Purva if that's okay. And then we hope to continue these series, Dystonia Education Series, provided we get a grant and we have the resources to do this. Hoping we will.
Thank you so much for joining, and we'll see you next month.
Bye, folks.